I do want to do an introduction again. Obviously, Dr. Lawson, thank you for being able to join us this morning. Um, so for everyone, again, Dr. Lawson is a author and speaker and a career mental health counselor. I know she joined us back in October with Dr. Ling, and he spoke about mental health awareness then. So we kind of just want to, again, kind of to piggyback off of some of the things we talked about the last time, Dr. Lawson, and I guess one of the questions we'll start with, as being a mental health counselor, we faced several challenges within the last year, obviously, with COVID, and it's definitely affected us in all areas, particularly with our mental health. Seeing as how we're entering now year two as a mental health counselor, what do you see as some of the biggest challenges with everyone's mental health going into maybe, I guess, our second year of COVID-19?
Yeah, I think the first thing I would mention is just that transitioning back to work, I've noticed has been an increased level of anxiety around going back into the workplace. Just getting back used to the routine. A friend of mine posted how she's only returning back 2 days a week, and the fact of the routine of getting up, working out, getting the kids ready, taking them to school, dropping them off, parking, walking into the building, getting her coffee. She was like, how did I used to do this 5 days a week before, right? And so that change of routine, going back into a building where, there's still a lot of discussions regarding the vaccination. Are you vaccinated or not? Wearing a mask, whether you're vaccinated or not. So the anxieties associated with that. And then just overall COVID fatigue, I think, is also a real thing. A lot of folks have reported to me they just feel the sense of lethargy, right? They're just not motivated. Things that they used to do, they either have lost interest or they just can't seem to get themselves together enough, quote unquote, to execute those things. And then when they share their experience or share their story, others tend not to normalize that experience. They'll say something like, well, we're all feeling this way, so what makes you any different? Or just get over it, or just figure it out, right? And so being dismissive is also, I think, another thing that's big right now as we enter into the second year of COVID.
Yes, I agree. There is often a lot of a dismissive nature in dealing with COVID, and particularly people's feelings and some of the anxiety and some of the frustrations they're feeling. So I definitely understand that. So absolutely. I know that a lot of times, particularly within our field, as being public health officials, we deal with, we don't, again, have in-house counseling here, but based off of, and I'm pretty sure Justine could agree, based off some of the intakes and newly diagnosed clients, there is a lot of possible PTSD involved. As a mental health counselor, can you speak to post PTSD and some of the signs and symptoms of that would maybe sort of assist us and assist others who do work in this field that are dealing with some clients who are facing some of those issues?
Yeah, definitely. So PTSD can show up differently for everyone. For some, it can show up as agitation. For some, it can show up looking like depression or anxiety. It can manifest itself periodically based on a trigger or a trauma response. It can show up. So one of the key things I think first is important is to be able to understand the difference between anxiety and depression, as those are the common two ways PTSD may surface. So when you think about anxiety, it's worrying about something in the future, something that hasn't happened. Is there a probability it can happen? Yes. Is there a probability it cannot happen? No, as well. So that's anxiety, that worrying about the future, whereas depression is there is a hyper focus on the past, right? And so when you think about depression, the person may be unmotivated to clean their house, their home, may be unmotivated to do personal hygiene, may be unmotivated to get out of bed. They may have racing thoughts. Trying to look at a quick little list I did. Oh, brain fog is a big one. brain fog, any kind of muscle pain or headaches, just that overall constant fatigue, or just unable to find those things that bring them joy. Things or hobbies that used to bring them joy no longer brings them joy. Uh-oh, I can't hear you.
I mean, it's
We're,
that we deal with. Again, a lot of clients who facing traumas that they are bringing to us, and it's very difficult for us to um, pinpoint some of those things. So this insight is very, very good to have, Dr. Lawson. Definitely appreciate it. So our theme this year that we came up with is standing up to stigma. And we know there are a lot of stigmas surrounding mental health. Can you speak to some of those stigmas that are surrounding mental health and how we can debunk some of those stigmas when we are dealing with our clients?
yeah, certainly. I think it's important to note that I think the stigmas have started to be lessened. I think what COVID brought on the need and the why it's so critical to have access to mental health resources. I'm on several EAP panels, and I have one EAP panel that normally only offers 8 sessions. They doubled it during COVID, right? And so they recognize that, hey, folks, our employees need additional support. I've seen companies offer to pay 100% of all the mental health sessions. I think that's an amazing step and acknowledgement on the importance of mental health. So we are seeing a decrease in the stigmas, but are there still some? Yes, certainly. I feel like for some folks, there's still this worry about how they'll be perceived or judged or viewed if they choose to engage in mental health services. I think in the past 15 months, I've written more FMLA paperwork, completed more FMLA paperwork than I have in my entire career. When folks do get the courage to say, you know what, I need I need time off to take care of me, they still have several questions before I finalize the paperwork about, well, will my boss find out? Will he or she call me? Will my diagnosis be, will they have, knowledge or access to my diagnosis? Will I be labeled differently or treated differently in the workplace? So education is critical, not only to the folks that we serve, our patients, our clients, but also to the employers, particularly HR and senior level management, so that they can say, hey, we have EAP, employee assistance programs out there that offers X amount of free services, free sessions, or have you considered ABC? ABC being, talking to your primary physician about some of the things you're experiencing. So being able to normalize and have those conversations in the workplace is critical. So I'm a big proponent in educating employers, particularly HR professionals and senior level management, on recognizing the signs and offering the assistance in a way that's, still allows that employee to make the choice on their own. That you're not saying thou shalt do this, but again, it's the choice of the employee.
Okay. Thank you, Dr. Lawson. Again, this is great information. And again, for the attendees, there is a drop-down box. If you guys want to ask any questions, any comments, please do that in the drop-down box. Um, I think we all have access, Justine, Emma, Megan. So if there's any questions in there, you guys can peek in there, and we can kind of see if we can answer those questions as we have them. And I appreciate what you said about the Lawson, because I think a lot of times working in this field, we are so visioned into taking care of the clients that we are not taking care of ourselves as much as we should. So that is very, very important. Um, so another thing that I know, because we talked about stigma as well, um, you deal with a lot of barriers within our field as far as barriers to care. Um, what do you see as some of the barriers to mental health treatment? What would you say are some of the things that are making folks reluctant to come in and getting treated? And can you speak to some of those barriers?
Yeah. I think the biggest one that I see on a day-to-day basis is if the person is insured by a commercial payer. So, I'm thinking like your Blue Cross Blue Shield, your Cignas, your United Healthcare. Um, every plan is different. And so helping the patient, the client navigate their health plan to see what coverage they have is a huge barrier, because the payers don't make it simpler, right? Simple. The insurance payers don't make it simple. That's why I always encourage my clients to first see if their employers offer any EAP, because we can go ahead and immediately access that. And usually it's at a minimum 3 sessions. During that time, while we're getting that ball rolling to figure out their primary insurance, we can start services utilizing their EAP services. So I think that's the first thing. Some insurance companies, believe it or not, still do not cover mental health services, which I think is so not fair. And so those folks having to pay out of pocket or find other resources to be able to access affordable mental health quality care, I think that's another issue. I think another barrier is finding a therapist, not knowing the process or understanding the process of finding a mental health provider. So if you think, first of all, finding a psychiatrist is like, and to get an appointment within 30 days is a miracle, right? It's the wait list is long. And then just finding a therapist and recognizing that it's like finding a hairstylist. The first one may not be the best fit. You may have to shop around, and in that shopping around, things could be escalating at home. So that's why I encourage folks to seek out a therapist early. Don't wait until things are really, really bad. Go ahead and establish that relationship, and so that you and your therapist have a rapport, have that working therapeutic alliance. And continue seeing your therapist after things are leveling out. Schedule a 3-week check-in or a month, or if eventually you get it to once a quarter. But having those kind of baselines and those relationships already established allows you to be able to engage in a different way when there is a crisis showing up. You can easily get on the books, and your therapist already has some familiarity of you.
Great. Sounds good. Sounds really, really good. Thank you, Dr. Ross. I know one of the things I was reading a little earlier this week, because again, this is Mental Health Month, is I'm trying to take with me is it's okay to not be okay. And there are a lot of people out here that we're dealing with, um, that aren't okay and don't have as you stated, don't have those resources, don't have the insurance, and don't have access to that care and everything like that. Um, and we do have one more question for you, Dr. Lawson. And again, I really, really thank you for jumping on. I apologize about some of the technical difficulties that we have had. We will do better the next time. Us being in this field that we're in, dealing with HIV and dealing with these newly diagnosed clients, attempting to bring clients back into care. What would be some of your advice to us as professionals when we're dealing with clients who are struggling with some of their mental health issues, and things of that nature? Speak to us and how we can better help them. Granted, again, we're not professionals, but how can we in our roles be more of a support to them?
Yeah, definitely. There's a famous book called Helpers Help Thyself, or Physician Help Thyself, or something like that. But yeah, we have to take care of ourselves first. Burnout is real. I'm also, in addition to being a therapist, I'm a counselor educator. And I tell my students on day one on understanding the difference between burnout and compassion fatigue, and recognizing our own triggers. Burnout can look like emotional exhaustion. It could look like cynicism. We become dismissive of our clients. We're not as effective or efficient in our roles. And so it's important that one, we're self-aware and do a check-in on ourselves, but also we as peers and colleagues holding each other accountable, tapping someone on the shoulder and say, um, hey, I noticed that you were a bit, snippy or short earlier today. Is there something that is going on? Do you think you might want to consider the EAP or engaging in some counseling services? But we have to hold each other accountable as well when we notice those signs of burnout, or noticing when you're getting a little extra crispy around the edges. There's a lot of talk about self-care. I feel like self-care has become so commercialized and
Right.
associated with price tag, and that it looks like a manicure, pedicure, bath, bubble bath, those kind of things. And while I don't want to be dismissive of those activities, I think self-care can be seen in a broader role and looked at as an act of a restorative care. And so when I say a restorative practice, I'm referring to those things, those intuitive process that really stand on acceptance and gratitude on where we are right now. So those things that bring us joy. So for me, an intuitive process or restorative practice that I do every day is coming into my office before the start of my work, turning on the lamps and not using the hard lights, using a lot of natural light, lighting a candle or having a diffuser there, so that when I do come in to officially start my workday, I feel like I'm walking into a place the scene is already set. There's already some sense of serenity. And then being grateful for that opportunity to have that ability to set that scene for myself so that I can work effectively with my clients. And then I think the last thing that's important for us as helping professionals is the importance of boundaries. I feel like as helping professionals, boundaries is our superpower. The
Right.
ability to set or establish a boundary is a sacred act. So, what that would look like with our patients or our clients is honoring the time limit of a session. If we know we only can get 15 minutes or 20 minutes, just honoring that, starting on time, ending on time, setting those boundaries, again, is a sacred act. Honoring those boundaries is a courageous act. And so these boundaries that I talk about are not limited to the workplace. They can be in the home as well. Having those boundaries with our family and friends, so that we can make sure that we have time to self-restore. I think we all heard of the old saying, you can't pour from an empty cup. I challenge
Yes.
that. I challenge that because I feel like depending on where you sit in your perspective, you may not be able to tell that the cup is empty. So you keep working, working, and working. So unless you stand over the cup, you may not know that the cup is empty. If you're just looking at the side of the cup, unless the cup is clear, you won't know if we're getting toward the end. So what I challenge helping professionals to do is to pour from your saucer. When I was a little girl, sitting at the kitchen table with my mom wanting to drink her coffee, she would pour it in a saucer for me and blow it, and I would drink from the saucer. And what I realized now as an adult, and of course she did that because she wanted a limited amount of caffeine I had access to, but also wanted to make sure I didn't burn my tongue. But drinking from the saucer means we'll be drinking or serving from our overflow, right? We ensure that we have enough for ourselves and we're giving from our overflow. So I challenge all helping professions, nurses, caregivers, um, therapists, anyone who's in a place where they're serving, to pour from your saucer and serve from your saucer.
Awesome. 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 Thank you so much, Dr. Lawson. We have a couple of questions in the chat. Um, but I was going to pick your brain a little bit more if you don't mind, ma'am. So, of course, one of the big things, of course, with COVID is, I'm sure you've dealt with is telehealth. This has been a big thing here as well. So I guess this is more sort of a two-part question, kind of ties into each other. Do you feel as though telehealth, telesessions are more effective than in-person sessions? And um, any suggestions, obviously, for connecting with clients in rural areas for therapy? That's the big issue we have as well. Not being able to get clients being able to have access to um, therapy and things like that in our rural areas, because we have a lot of them here in our area. So can you speak to that, ma'am?
Yeah, definitely. So I think there's a place for both telehealth as well as in-person sessions. So telehealth sessions have been going on, believe it or not, for years, like over 40, 50 years. We forget about how therapy actually started with one writing a letter to their therapist, their therapist responding back in the letter. That's virtual services. That's telehealth, and before Wi-Fi, of course. So is there value in having sessions virtually? Yes. Is there value in having sessions in person? Yes. Is one better than the other? No. I think it depends on the person and the presenting problem. Some things can't be are best handled via a telehealth situation, i.e., if a person is has suicidal ideations, that's something that I think should be handled in person so that we can do a better assessment. Any past history of self-harm, again, needs to happen in person so that we can get a clear assessment of that individual. I enjoy doing virtual sessions. It does give that ease. When you're working with some clients with some traumas, particularly sexual trauma, that kind of thing, it is helpful for them to do those sessions in home where they're a place where they're already comfortable. They have access to those things that help them regulate emotionally. But again, I think it's on a case by case basis, depending on the diagnosis, severity of the situation. In regards to folks in rural areas, the challenge again is access to reliable Wi-Fi. So that's a big issue. Access to being driven to services that might be 30, 40, 50 miles away, that's the issue. So what's the happy medium? I think in those cases, we have to literally meet our clients where they are. So this is where there's an opportunity to offer those in-home sessions, opportunities to offer to use churches or other community centers as a place where we can maybe meet once a week or every 2 weeks to be able to offer the services so that they have some accessibility. I think we need to continue to think through, and I say we as the helping profession, uh, as insurance companies need to think through what that looks like. I've noticed some insurance companies have already started to scale back services that they're willing to pay via if they're offered via telehealth. So I think it's going to require us to advocate for our clients, our patients, on being able to still offer this access, but then also think of how can we continue to provide even more access to those individuals who don't have reliable Wi-Fi, who don't have reliable transportation, or who aren't in a 20-mile radius of being able to access services.
Okay, thank you. Thank you so much. We appreciate that. Justine, can you hear me? Okay, I see you posted a question in the chat.
Mhm, mhm.
Did you want to ask Dr. Lawson that while we have her for the next few minutes? We have about 12 minutes, guys. So
Yes, please. As the navigator, I see a lot of young men coming in that are MSMs and have not disclosed. So now they're HIV positive and they're anxious, they're depressed, they're going through a lot of different stages, afraid to tell their family. Help me on how to handle and advise those clients and direct those clients at that time.
Yeah, that's not a population I work with. That's not within my niche of services. But I think one thing that's important is to help the individual understand or walk through some of their fears or judgments that they're concerned about. So one activity that I do with clients, and I think this can be used with this population as well, is often they'll say, well, they will think XYZ or they will say ABC. So I have them break down the theys, like who is that? Like let's name them out individually. We list those individuals out. Next to that, we list what they think the response would be. And then the next column is how would we respond? What I found in that activity is that the they may only be one or two people, and those one or two people might not be persons that they hold in high regard, or their opinions aren't meaningful or matters to them overall. So oftentimes I find that the client tends to have magnified the impact of what their disclosure may or may not look like. So that's one tool we use. Second thing is to help the client better understand the importance of familial support, family or friends. I feel like family can be chosen, those ones that are, chosen and that were given to us biologically, but also ones that we get to choose, right? And so what does that support system look like? And then why is it important for us to make sure our support system knows our truth so that we can stand authentically and get that support that we need?
Thank you. And my second
Thank you.
question with that tied in basically with that, and it's in our area, church and culture. Just to give you an example, I met with a young gentleman this week, and he, disclosed that his risk factor was heterosexual. Then in the conversation as we got going, he also indicated and he disclosed that there was MSM, that he had had sex with men in the past. He denies having sex with men currently. But part of the issues that he was struggling with was the church and the church belief and the church culture and his family and how his family would view because of the church dynamics. And we do live in the belt.
Justine, we are the buckle on the belt. Yeah, church trauma is real, and I think we're
Yeah.
slow to get into it. Recognize that church trauma, church hurt is real. I do a lot of work. When I say a lot, let's say maybe two or three churches on just having the conversation about mental health from the pulpit, right? And so I think it has to start from the pulpit, from the leaders in the church to begin to normalize depression, normalize anxiety, normalize the trauma. I think from there, I think it's a long road to hoe. Eventually, we can get to the point where we can talk about sexuality and sexual health and how the church has only made that even bigger of an issue than what we recognize.
Yeah, I would agree.
I agree as well. I agree as well. I think we have one last question, I think, for Dr. Ross. I think we can try to wrap and give our closing remarks. Um, so on the National Alliance on Mental Intelligence website, I was doing some independent research, and it's one study showed 63% of African Americans feel like revealing mental health issues or mental health conditions is a sign of personal weakness. Um, Growing up, of course, in a household like that, we are often told, oh, we don't cry and don't express ourselves in certain ways, particularly a male. Um, and we do deal with a lot of course, people diagnosed in this. We know that HIV indirectly has a effect on Black and brown communities. Um, what are some of your thoughts about um, that being a stigma within Black and brown communities, Dr. Lawson, your experience in dealing with that, communities of color not wanting to deal with mental health conditions, seeing it as a sign of personal weakness?
Yeah, definitely. I think part of it goes back to the whole church perception that one should just pray more or have more faith or belief. And so that lack of belief is what's contributing to that person feeling down, or I like to hear, I chuckle when folks say, oh, I'm just a little depressed. I'm like, can you be a little pregnant? You're either pregnant or you're not, you're depressed or not, right? But I think that it goes to that whole belief system around church culture that you just need to pray more, believe more, tithe more, do more, give more, kind of thinking. I love this new emerging generation, um, particularly my younger millennials. I think they are revolutionizing the way we think about things. I love the way they're going after social injustice, right? I love the way that they're embracing mental health and making and talking about it in pop culture. We're seeing more celebrities talking about their challenges with mental health and that kind of thing. So I think that I high five these millennials. I'm kind of known as the auntie to the millennials, and I love the fact that they're knocking at my door and want to seek services, and they're sharing to their parents, yes, I'm in therapy. You need to do therapy too, right? And so being more vocal about what that means for them. I was even working with a 40-something-year-old, and she was sharing that her father, when she disclosed that she was in therapy, he was like, "What's wrong with you? Do we need to get you medical attention?" But not recognizing just the importance of not only physical health but mental health. But I think that this generation is becoming more vocal and sharing their experiences with their parents, with their aunts, and with their uncles. So I believe that can get into open up a lot of doors and changing the conversation.
Absolutely, absolutely. I was having a conversation with my brother, specifically within the last year, seeing so much um, things with COVID, particularly also with social injustice, just to see the new generation mainly out in the streets expressing themselves, being more vocal, and also being more apt to seek mental health counseling. Even in my age, my generation, and the generation that precedes me, still kind of see it as a taboo thing in some cases. So that's really, really good, good feedback, and really appreciate it. So, in kind of want to wrap this up. I'm going to start with Megan and Jenny. You have any closing remarks?
Now, again, just want to remind everybody that, if they're suffering from any anxiety or depression, that, we here at Care Team, our clinic staff, our providers, our nurses, our case management, prevention and outreach, they need to just give our office a call and come in and speak to us. Let us try to help them get the help that they need, whether that's here at our office, whether that's a referral to a local therapist or psychiatrist to MUSC. There's a lot of options out there, and they don't have to feel that they're alone in this. And we'll do what we can for them.
Emma?
Hi. Yeah, I just want to say, I mean, like Jen said, we are here. We're here to talk or help you find the resources that you do need. But also, I want to say, speak out. Like Dr. Lawson said, our younger generation is doing that, and we need to stand behind them. We need to be there beside them, and we need to let them know that it is okay to talk about this. So hopefully, in the next couple of generations, we won't have to worry about this anymore. But talk. Make it, normalize it, make it okay. So, and thank you, Dr. Lawson.
Well,
Justine?
Thank you. I have learned a lot. I was taking notes, and so that I can use some of the advice that you have provided to, you know, I appreciate your time. I appreciate care team. I will be referring and, you know, continuing as I have, you know, to talk to the providers as well so that we can do the MUSC referrals and then let the providers determine if we need to, you know, make that referral to Waccamaw or any of the local counselors that we have, which we, you know, all the case managers, you know, do. And I think we do, you know, fairly well. And thank you, Jen, for always being there when we need you.
Yes.
Thank you, Brandon, Emma, Dr. Lawson. Thank you for this.
Dr. Lawson, any final words?
Yeah, so this is Mental Health Awareness Month, and trying to see what I just posted something. I can't put my hands on it right now, but just recognizing that we need to normalize these discussions. So I encourage church leaders to talk about it, recognizing that mental health is a social justice issue. It's not a Black issue, a brown issue, a white issue, a blue issue. It's all of us. And the more we normalize this and recognize that mental health is just as important as physical health, just as if you find out that you have diabetes, treating your diabetes is essential. Treating your anxiety, depression, trauma responses, trauma triggers are just as important.
Awesome. We had some logistics problems in the beginning. I apologize for that, Dr. Lawson. I do hope and pray that you will at some point in the future join us again. This is great information. And for all the attendees, thank you for your questions that you sent to the chat. I did put the suicide prevention hotline number in the chat. Of course, we do know that unfortunately people who are in deal with mental health issues do often, unfortunately, take their lives and things like that. And we have a tough job in what we do here. You know, dealing with, of course, the diagnosis and some of the other physical health issues. Mental health is a huge issue. And as you said, Dr. Lawson, we have to normalize these conversations. And I think that is changing around here, which I'm very excited about. And if that is all from everyone, we're going to wrap this up. Thanks to all of you that attended. Then we will put this together in a more next time. So we will share. So, Dr. Lawson, again, thank you. Justine, Megan, Jen, Emma, I appreciate you guys. And until next time, have a great day.
Thank you.
Bye-bye.
Bye-bye.
Bye.